I'm starting with today's session now. Greetings and a warm welcome to all the dignitaries present here. I am Shwastika from Team Clarnet, serving as the allocated session assistant to ensure a seamless experience. Clarnet proudly stands as India's most relied upon digital platform, offering a multitude of enriching services exclusively for the doctors. It is with great pride that Clarnet serves as a digital partner for this event. And the focus of today's session is Trans-Esophageal Echo Cardiography TEE. And now, I would like to invite Dr.AL.Meenakshi Sundaram Sir, a distinguished anesthesiologist and academic leader. Sir has served as a Dean and DME at several government medical colleges, including Theni and Stanley Medical College, Chennai. He is a former National Vice President of Indian Society of Anesthesiologists and has held key positions including Governing Council member, President and State Secretary of the ISA Tamil Nadu State Branch. Now, sir, we will be proceeding with the session. Over to you, sir.
Thank you, Clarinet, for that nice opening remarks. Now I welcome all of you for the 45th webinar under the caption Puthukkottai Bhudhan, second edition. I like to inform all of you that the 44th webinar of Puthukkottai Bhudhan, second edition was held on 19th November 2025 and the theme was autonomic nervous system. So the faculty were Dr. Shashank Hairmath, postgraduate, Dr. Bhargavi Sankat, and Dr. Yatish, uh, and it was moderated by Dr. Sandhya. All faculty are from Bangalore Medical College and Research Institute, and I want to inform 994 members attended the last webinar live. So it is a great number, 6 short of 1,000, and Puthukkottai Bhudhan has crossed 1,000 twice. The 12th webinar on bowel apparatus and 42nd webinar on non-operating room anesthesia had delegates above 1,000. And today, this webinar is peculiar, the presence of faculty. Routinely, we had so many of webinars, all faculty from same college several times. And most of the times it was pan-India also, one faculty from each state. So many permutations, combinations happened, but today, this is peculiar because this time two states are participating. That is TamilNadu and Kerala. And at the same time, two male members and two lady faculty are participating. So this time it is a equal chance 50-50. And the youngest faculty today is going to be Dr. Prahanth. He has done his MBBS from Venkateshwara Medical College and Research Center, Puducherry. He has completed his MBBS in 2016 and he has done his MD in BJ Medical College, a popular medical college in Ahmedabad. And he has completed his MD in 2022 and now he is pursuing DM cardiac anesthesia in Chitra Tirunal Institute. That itself says he is a keen academician. He is progressing, and at this time, all the faculty are DM cardiac anesthesia. So we have to appreciate that. What I want to convey, Puthukkottai Bhudhan is very particular in selecting the faculty. So this Dr. Prasanth, more than this academic caliber, he is interested in playing badminton, and now I don't know whether he is continuing to do so because the moment they join MBBS, they lose all their extracurricular activities. But I wish him to develop that badminton culture also. So it will be followed by Dr. Rohini. Dr. Rohini basically has affinity to Puthukkottai as her in-laws house is situated in Puthukkottai. That is our ISA city branch area. And she has done MBBS from Dr. Ambedkar Medical College and she has done her DIP NB. And usually we used to say DIP NB is tougher than MD. And she has passed the DIP NB from Fortis Hospital, Bangalore. And subsequently, again, she has graduated in DM cardiac anesthesiology from Jayadeva Institute of Vascular Sciences, Bangalore. So that is also a renowned institute. So when he is doing DM cardiac anesthesia, Dr. Prasanth, Dr. Rohini is a qualified cardiac anesthesiologist, and he in FIACTA, that is cardiothoracic anesthesiologist. She is a gold medalist in 2019. She has won the gold medalist, and she is a fellow in trans-esophageal echocardiography in 2019. So she is the most shrewd academician, intelligent, and she is a good orator. And see, with this curricular activity, she has not stopped. She's having so many extracurricular activities. She's a trained Carnatic vocal musician. She is a Carnatic vocalist, and she is trained in yoga. And she is a vice president in Lions Club International Trichy Sakti branch. She will be roaring like a lion in all conferences I have seen. And she is a volunteer with Nightingale's life saving services, and she is the recipient of Duke of Edinburgh International Award for Young People. So at the youngest age, she has won that. Even now, she continues to be young, and she is enjoying gardening and spending time with the pets. I don't know what she means by pet. Probably her spouse, and she loves to have the craft activities. So we welcome Dr. Rohini Mayur Balaji for this, and it will be followed by Dr. Mamatha Munaf. She is from Chitra Tirunal Institute of Medical Sciences. Again, she is qualified in DIP-NB. So these two faculty are qualified in DIP-NB. A DM, she is also a DM cardiac anesthesiology, and more than that, he has done a pediatric cardiac anesthesiology also, and she is also a fellow in TEE, and she is the ADVP TEE testimer. So her affiliation now is assistant professor, Division of Cardiothoracic and Vascular Medical Sciences, Chitra Tirunal. Same way, Dr. Rohini is from Apollo Hospitals, Trichy. So Dr. Mamatha Munaf's MBBS is from JIPMER, prestigious institute. Again, MD from JIPMER, prestigious institute. DM Cardiac Anesthesia from Chitra Tirunal, prestigious institute. Postdoctoral fellowship in pediatric cardiac anesthesiology, that is also from Chitra Tirunal. So that shows she is a high-end academician, and her achievements are: she has won Sudha Balan Memorial Endowment Prize and Gold Medal in ENT, TN Jha and KP Sansurya Travel Grant and National Award for Best Paper Presentation in 2016 ISA Ludhiana. She has won the national level anesthesiology quiz, second prize. So I recollect, as a postgraduate, I also won the ISA National Conference quiz program in Bangalore, second prize. Madam has also won the second prize, but I have stopped studying with that. But Madam is continuously progressing and reaching greater heights, and she has won the first prize in national level echocardiography quiz competition by conducted by cardiothoracic anesthesiologist, and she has won second rank in the national level FTE 2022. So in transesophageal echocardiography, she is a fellow and she has won the second prize. Same way, Dr. Rohini is also a fellow in TEE. That is the reason why they are delivering a lecture on TEE, and I request the delegates to utilize them. And Dr. Mamatha, in addition to all these things, she is interested in painting, dancing, and writing. So, such a great and academician having extracurricular activities is participating in Puthukkottai Bhudhan. So, now these are all the great people qualified in cardiac anesthesiology and delivering a lecture on TEE. Most of the people might not have seen what is a transesophageal echocardiography. Even to see that, I have visited a corporate hospital, how the TEE is being performed. So, to moderate all these three people, we need a giant in anesthesiology, especially in cardiovascular anesthesiology. So, we have catch hold of Dr. Saravanababu. He is associate professor and HOD in charge in All India Institute of Medical Sciences, Madurai. Previously, he was in Chitra Tirunal, Trivandrum, and he is native of TamilNadu, that is Kanchipuram, and he is interested in cardiothoracic and vascular anesthesia necessarily. That is the reason why he is qualified. In addition, he is interested in enhanced recovery after surgery. He is interested in perioperative echo. So he is interested in TEE also, and he has 85 publications, all in indexed journals. And he is the author of textbook chapters. He has authored 8 chapters on textbook, and he has won the first prize in quiz program in perioperative anesthesia in Jalandhar conference, Punjab. So he has won the best paper presentation, comparison of epidural ropivacaine with the dexmedetomidine for perioperative analgesia after spine surgeries. So he has won that. It was held in Varanasi, and he has won third prize in post presentation. Utility of intraoperative TEE in assessing the operability of high risk single stage Fontan procedure. So he has won that, and he is having a best logbook award in TEE fellowship examination conducted by Indian College of Cardiac Anesthesia. So this man is also very good and having a high caliber in TEE. That is the reason why he is at this level of a moderator, and he is a reviewer in national and international journals. He is also a fellow in TEE because when the faculty are having that qualification, the moderator is also having that qualification, and he is a FIACTA examiner of Indian College of Cardiac Anesthesia, and he is a university topper in MD postgraduate. So one has won the gold medal, another one has won quiz prizes, and now he is a university topper, and he is the right choice to moderate this session. And these three faculty are the right and hand-picked people who are well versed, and day in and out they are living with trans-esophageal echocardiography. With this introduction, I hand over the session to Dr. Saravanababu to carry out the scientific proceedings. Please, sir.
Yeah. Thanks for the introduction, Dr. LM sir, and it was a great pleasure for us for inviting and giving us a session on transesophageal echocardiography in your Puthukkottai Bhudhan forum. And as you all know that now the thoracic echocardiography has become an important armamentarium in the field of anesthesiology. So the transthoracic echo is most important vital a tool in perioperative management, and but the transesophageal echocardiography has not reached to the level of intervention among the general anesthesiologists. So the transesophageal echocardiography has an important role not only in cardiac surgery. Now the guidelines has come that most of the transesophageal echocardiography indications are needed in non-cardiac surgeries as well. So taking into this account, today we are going to have 3 sessions. The first session will be on transesophageal echocardiography probe, handling of the probe and sterilization, and what are the components of the probe and how the image is produced with the transesophageal echocardiography. So the first session will be given by Dr. Prahanth Durai, as already introduced by Dr. A.L.M. sir. So I hand over the session to Dr. Prahanth D to continue his lecture.
Thank you, sir, for the warm welcome. Good evening, everyone. Now we are going to discuss about handling and sterilization of the transesophageal echocardiography probe. So transesophageal probe is a thin flexible tube with an ultrasound transducer present at the tip, which is inserted via the mouth and esophagus to make high quality detailed images of the heart. It provides us a real-time dynamic evaluation of the heart images, and currently 5 to 10% of the all echocardiographic procedures are done with the transesophageal echocardiography probe. So this is the transesophageal echo probe, where we can see the transducer lens at the tip, and the bending portion will be seen above that, and one flexible shaft will be there along with the control housing. The control housing has transducer control. Two wheels will be there. One is larger inner and smaller outer wheels. And then the system cable, which is connected to the echocardiography machine, that is called connector side. So as we can see here, the first image is focused about the distal tip or lens of the transesophageal probe, above which we can see that bending portion, which we can control with the transducer control. This is the full shaft. The second video showing full shaft. The adult probe is about 100 centimeter in length. And in third image, we are seeing the control housing with the larger and the smaller wheels. And this is the button for change in omniplane angle from 0 to 180 degree. So this is a GE machine echo probe. These are the textures for grip, and the above one is attachment ring. And this is the, as we discussed, larger and inner wheel. And this is the button this is the button for omniplane angle change, and the middle button is for image acquire. This is the connector side view, and the fourth image is the connector view, which is inserted to the machine end of the ultrasound echocardiography machine. So the key components of the shaft is it consists of a coaxial cable. In the central conductor will be there, which will be conducting electricity. To prevent that dispersity, we are having dielectric insulator over the central conductor. And then the third layer is like outer layer is plastic jacket, which is exposed to the patient's gastric mucosa. So American Society of Echocardiography 2013 guideline describes the probe manipulation. As we can see in A image, we can advance the probe or withdraw the probe into the esophagus to the stomach, or from the stomach to the oral cavity. And then we can turn the full probe to the right or left direction. So these are the probe manipulation. And the tip, the bending portion can be flexed in 4 directions using the transducer wheels. So these 4 motions are anti-flex and retroflex, and flexing to the right and flexing to the left. And the omniplane changes, the tip itself doesn't change its direction. Only the axis of image V will be changed from 0 to 180 degree. So in B image, we can see the views of transesophageal probe. Either it will be upper esophageal or mid esophageal or transgastric and deep transgastric. So these are the outer and inner wheels of 2 different TEE probes. The second image is from GE machine, and third is from Philips machine. The indication is like AP and R and L. So the inner part, if you rotate clockwise, it will be anti-flexing, and if you do counterclockwise rotation, the probe tip will go in retroflex position. Same like this, R and L predicts the clockwise rotation rotates to right and counterclockwise to the left. So as we can see, clockwise rotation produces anti-flexion, and counterclockwise position moves the tip probe to the retroflexion position. So the outer wheel, if you rotate clockwise, the probe tip will be flexed to right side, and if you rotate counterclockwise, it will it will flex to the left side. This again shows the control housing with the probe tip portion. We are changing we are rotating with the larger control wheel, anti-flexion, retroflexion, and with the help of smaller outer probe, this is probe flexion to the right, and the final image is counterclockwise of a smaller control wheel. rotates to the left side. Till now we have seen the adult TEE probe, and this is the pediatric TEE probe. Wherever the word T is written, that is trans-esophageal probe. This is Philips S73T probe. This is the connector end. And the fourth image is how to insert. So we have to keep the mouth gap after giving anesthesia. This may sometimes pushes the tongue posteriorly. So when pushing the TEE probe into esophagus, many times we need jaw thrust to be given for that smooth insertion of the transesophageal probe. This is the TEE probe of pediatric patients. As we can see, the both wheels can be present, but the outer wheel will be omniplane change angle. So it is not like right and left flexion as we seen in adult TEE probe. So inner wheel is for anti-flexion, retroflexion, and the outer wheel is for omniplane angle change. And the length of the esophageal probe for pediatric patients are 70 centimeter. So this again, inner probe, inner wheel, anti-flexion and retroflexion movement. But the outer wheel doesn't produce any changes in the tip, but it changes the angle from 0 to 180 degree. So regarding handle, all these movements, one should know about all these movements and anatomy of the transesophageal probe from the connection to the distal tip, and it should be carefully handled during procedure and after procedure, like during transportation and storage. And you should use proper and mandatory use of bite guards even for conscious sedation patient and whenever patient in general anesthesia. And third point is strict decontamination process should be done between each patient use. And the regular testing of the probe articulation mechanism is used in between patients use. And electrical leak testing should be done before patients use. So this is do's and don'ts of TEE probe. Always use a scan head protector during all phases of transportation. Like here they are covering the control housing with the plastic sheet, and the connector end should be closed properly whenever not in use, and store the probe so that it hangs freely. So the silicon cover should be put in the tip, and it should be hangs freely vertically, and it should be stored in environment where there is good airflow, and always use only water-based lubricants. What we are using is 2% lignocaine jelly, and rinse the probe thoroughly, especially final rinse. And whatever the manufacturers of the TEE probe or TEE machine prescribes, we have to use such chemicals only. And even the soak timing also determined by the manufacturer side. And disconnect the probe carefully by gasping the connector and pulling gently. And always use bite guards for every procedure. The above picture shows bite guards for pediatric patient, and lower one is for that yellow is for pediatric, and the white in second image is for adult bite guards. So do not store TEE probe in a drawer or any shipping case, and do not submerge the handle. Only the 100 centimeter shaft and tip should be immersed in the detergents, and do not allow moisture to enter to the systemic connector, and do not over soak the probe in enzymatic or high level disinfectants. So while removing the probe, it should be removed carefully. After removing the probe, we should remove the mouth bite guards also carefully without damage to the tip of the TEE probe and to the patients. After removal, we have to check the probe. We have to clean the probe, wipe off from the patient's secretions and lignocaine jelly, and you have to assess from the tip to shaft any bite mark or there or any other injury is there. So visual inspection is necessary of all the parts of the TEE probe, like control housing, any dirty or crack is there, any missing pieces are there. And the shaft, you have to look for any bite marks or broken or chemical damage is there. And the bending portion should be checked. And finally, the lens tip should be checked. Sometimes the bending rubber will have the protein binding because of inadequate disinfectant usage. And sometimes heavily crusted flexible shaft can be present. So you have to check each of the parts of the TEE probe after removal of the TEE probe. So these are such some examples of TEE probe damage, like unapproved disinfectant use, not suggested by manufacturer. So it will cause the cracked proximal bead. Here, because of improper cleaning, human protein buildup in the peripherous areas of the lens tip. And in third image, we can see the upper part, some silicon beading is removed from the lens. So cleaning defines removal of all visible soil and contaminants from the transducer. It must be cleaned after every use before sterilization. After removing and wiping off, we have to clean with running water for about 1 minute. And after that, detergent should be used for cleaning. So the water should not touch over the control housing. Only the tip and the shaft of the TEE probe should be cleaned with water and detergents. The second process, and after that you have to rinse and dry it properly. The second phase of sterilization is decontamination. So estimating the infection risk is very difficult. There is no clinical studies regarding infection using TEE probe. So as it is compared to upper GI scopy, the risk of transmission is 1 in 1.8 million studies, but that is for upper GI scopy. So the chances of infections are H. pylori, Pseudomonas aeruginosa, Salmonella, and Mycobacterium. Even hepatitis B, C, and HIV is possible. There is no proven studies or anything with the TEE probe per se. So the decontamination room should be separate, and it should have a sink storage, sinking area, disinfected storage, and either automated endoscopic reprocessor or manual disinfection. So always follow the instructions by detergent manufacturer to dilute the detergent. So here we can see only the labeled three. Three is that tip and flexible shaft should be immersed into the high level disinfectant, not the control housing or the cable or the connector. So this is what we are using in our institute. This is the manual disinfection. The content is 2.45% glutaraldehyde Sidex solution. So you have to keep both the bite guard and the flexible shaft of the TEE probe inside, and you should allow it to stay for 20 minutes. And after 20 minutes, we have to remove it and we have to rinse again with water. As Sidex is chemical, this will cause irritants for the next patient. So you have to clean it with running water for about a minute and rinse, and you have to dry it completely. So the summary of the decontaminations are pre-cleaning. After removing, you should wipe off completely, and you should wash with running water, then detergent cleaning. Then you have to dry it completely. Then high level disinfection you should use. It may be Sidex or some other percentage of glutaraldehyde. So this high level disinfection destroys all the microorganisms except bacterial spores. Then again we have to rinse properly, then drying it, then storage in vertically hangs and good airflow region, and again reuse. So the take home message will be TEE probe must be cleaned after each and every use, and whenever after removing and introducing into detergent or high level in disinfectant, always use protective eyewears and gloves, and ensure detergent strength and duration of contact as by manufacturer, and always use bite guards whenever TEE probe is used. And it should not be treated with the autoclave, gas inhalation, gas sterilization, steam or heat sterilization, gamma radiation, and bleach. And it should be thoroughly dry before storing, and do not bend the shaft of the TEE probe into circle with a diameter of less than 0.3 meter. And TEE probe should be articulate only with the controls, not with the hands. So to check for the motion, always you have to use the wheels for the motion check. So these are my references, and thank you for the opportunity.
Yeah. So thank you, Dr. Prasanth, for a good basic lecture on how to handle the TE probe, as well as the how to sterilize the TE probe post examination. So basically, the TE probe is like a fiber optic bronchoscope where the camera is placed with the camera tip, where the fiber optic scope is placed with the camera tip, where the fiber optic light source at the tip. The same way, the ultrasound transducer is placed at the tip of the transesophageal probe. So same way, the manipulations of flexion and retroflexion of the fiber optic bronchoscope, the TE probe is also used to flex and antiflex to position the transducer over the heart to capture the images of the various structures of the heart. Additionally, there will be an omniplane angle which rotates the planes to get a better image of the cardiac structures. So, and also the cleaning process and the sterilization process was nicely demonstrated with good videos. And with this, we'll go to the next topic of the today's session. The next topic is transesophageal echocardiographic views for the non-cardiac anesthesiologist. So the published guidelines are saying almost 28 views has been useful to image the heart by transesophageal echocardiography. But for basic anesthesiologists, what the basic views that are needed for the non-cardiac anesthesiologist to diagnose and to examine the heart is very much needed. So in the next lecture by Dr. Mamatha Munaf, so we can able to understand the echocardiographic views that are very much needed for the non-cardiac anesthesiologist. So over to Dr. Mamatha Munaf.
Good evening, everyone. First of all, I would like to thank Dr. Meenakshi Sundaram sir for this opportunity, for his kind words and warm welcome. Similarly, all thanks to the ISA Puthukkottai branch for this opportunity, and special gratitude to Saravana sir as well, who's my teacher. So today we'll try to see about the echocardiographic views of in transesophageal echocardiography for non-cardiac anesthesiologists. So the eyes cannot see what the mind does not know. So many times we see certain things, but how to interpret and make sense out of it, how to select the correct image for its appropriate use. That is what we'll be focusing on in this small talk. So I have divided this lecture into a small pre-test. Then we'll have indications and contraindications of TE, basic movements of TE, which Dr. Prasanth has already covered, selected TE views of relevance, and a small post-test. So to start with, see, you're seeing heart in this view, and which coronary artery supplies the territory marked by the arrow. Is it inferior, right, left anterior descending artery, or obtuse marginal artery? Similarly, we have a structure in the heart that is shown here, and arrow mark is pointing towards what structure? Is it right ventricle, right atrium, or left ventricle? So by the end of this session, hopefully we should be able to interpret basic images. So it is equally important to know when not to do a thing, as it is important to know when to do a thing. So let's discuss about the indications and contraindications of transesophageal echocardiography first. So for cardiac surgery, there is usually no confusion. All open heart surgeries and thoracic aortic surgeries are considered to be an indication for using transesophageal echocardiography. And in small children, very often it is said that TE should be considered on a case-to-case basis. So depending on the risk that are unique to that particular patient, we can decide. But when it comes to non-cardiac surgery, indication is not very clear-cut. Suppose you have a patient who's undergoing a planned surgery where the pathology might result in significant hemodynamic, pulmonary, or neurological compromise. Then you can consider using TE for that case if available. Similarly, suppose you have a patient who is undergoing a non-cardiac surgery, but He's having an unexplained circulatory instability. Despite you doing everything possible, all the corrective therapies are done, still he's having an unexplained circulatory instability. In those cases, if TE is available, TE should be used. And in critical care, when should you use TE? Suppose you have an unstable patient and you have used all the modalities available like transthoracic echocardiography, but you are unable to get the information in a time-bound manner. In that case also, you can use TE. So in cardiac surgery, you can use TE for open heart procedures and thoracic aortic procedures. For non-cardiac surgery, you can use when the patient is unstable, you have done all the corrective measures, still patient is unstable. In that case, you can go for TE if available. And in a critical care setting, if the available modalities are not giving you adequate information in a time-bound manner, then opt for TE. And when not to use transesophageal echocardiography. So as previously discussed, transesophageal echocardiography or GRAM is a tube-like structure which is inserted into the esophagus. So due to whatever reason, if you have an esophageal perforation, stricture, bleeding, then laceration, tumor, diverticulum, in all these conditions, you should not introduce a transesophageal echocardiography probe. There are a few other relative contraindications as well. So patient has a history of a recent gastrointestinal bleeding, or the patient has history of radiation to head and neck region. He has history of dysphagia, restriction of neck mobility. Dr. Prasanth has previously shown a video where a few maneuvers are shown to introduce the TE probe. So you have a patient with restriction of neck mobility, or who has known esophageal varices, has some bleeding disorders, coagulopathy. All these are conditions where it is a relative contraindication. You should decide on a case-to-case basis. So if you ask me personally whether I will use TE in such a case, I will not use. So what are the complications of transesophageal echocardiography? It is a relatively safe procedure. Out of 100 patients, maybe 2 patients might develop some complication. And most of them are very often mild complications. Most common complication is usually lip injury, dysphagia, hoarseness of voice, which are transient. It will settle after some time. But there are dreaded complications like major bleeding or esophageal perforation, which are extremely rare, but it can happen. So while introducing the probe and handling the probe, we need to be gentle and we need to be careful. But you should not be scared that every other patient you do TE in is going to land up with one of these complications. That is not usually the case. These are extremely rare. This is a paper which was published by our team where the patient had massive hematemesis postoperatively. There were a lot of discussion as to the cause, whether TE is responsible for the bleeding. Later it was found to be a ulcerated or a gastric ulcer which was eroding into a gastric artery. After coiling the artery, patient became completely symptom-free. So common things are more common. It is the other confounding factors that are very often responsible for the bleed. And the most common complication is often lip injury or hoarseness of voice. So it's a relatively safe procedure. Now, Dr. Prasanth has already discussed this topic. We'll quickly just glance through a few of the points. So as Dr. Prasanth already discussed, this is the major wheel and this is the minor wheel and this is the multiplane angle. So when you are moving the major wheel, so in that itself, there will be marker as to which direction you should turn it for anteflexion and which direction you should turn it for the retroflexion. So when you're moving it in one direction, it is moving forward anteflexion, other direction retroflexion. Now the upper wheel is the minor wheel. If you are moving it left or right, the probe tip also moves towards the left or right. So basically ultrasound will be produced by the tip of this probe. You can steer it in a particular direction by these movements. Now turning left or right means that you are turning the probe completely to either of the direction. And the fourth is advancing and withdrawing. So the movements which we saw till now are anteflexion, retroflexion, flexion to left and to right by the minor wheel, then turning the probe to right and left, and advancing and withdrawing the probe. So these will help us position the probe and steer the sector correctly. Now, let's talk about multiplane angle. So here you can see the button which this gentleman is pressing, that is, and you can see the angle which is changing in the screen in the left panel. So that is what we mean by the multiplane angle. So if you can keep your hand like this, your left hand, palm facing upwards, you can see that it creates a slice. It creates a sheet of ultrasound waves. And that is the line, or that is an assortation of lines that is cutting across a structure and giving you an image. So when I'm changing the multiplane angle, the thumb is moving up. So this is 180 degree. This is 0 degree. This is 90 degree. So that is what in the right panel it is being shown. So when we change the multiplane angle, it changes from 0 degree, 60, 30, 60, 90, to whichever angle is required to obtain the image, we can change the multiplane angle. So now we'll proceed with a selected set of TE views. These are the high yield views which I have selected for this discussion. There are 28 views which are described. In addition, there are some modified views also. But if we follow these few views, usually you'll be able to get relevant information in a time-bound manner. So as already discussed, in the esophagus, and this is the stomach, we can position TE at multiple levels. It can be just introduced, then push further inside, then into the stomach and well into the stomach. So upper esophageal views are there, mid esophageal views are there, where it is positioned almost behind the left atrium, then into the stomach, where it will be cutting the LV, and further into the stomach. So of these views, today we will discuss about a few relevant mid-esophageal views, transgastric views, and one deep transgastric view. So in mid-esophageal view, as I already said, it is usually placed somewhere around the left atrium. It's not hard and fast that it will be placed behind the left atrium, but that is the usual location. So in this panel, if we see, this is where the probe is placed. Imagine that this is the esophagus and you have a transducer here. So it is producing a sheet of ultrasound waves. And this will be the, wherever the thumb is, that will be on the lateral part of the screen or left side of the screen. And wherever the ulnar border is there, that will be the right hand side of the screen. So when probe is placed behind the left atrium, it is closest to the left atrium. So whatever structure you see closest to this triangle, because this is where the probe is, whichever structure you see here will be the left atrium, or whichever structure that is closest to the probe. So now at 0 degree, I am just slicing across the heart. And what are the structures that we can see? So if you look here, as I said, you're just slicing across, this is the left atrium. So left atrium opens into some structure across a valve. So that has to be the left ventricle, and this has to be the mitral valve. Similarly, next to the left atrium, you have another structure. That will be the right atrium. And right atrium will open into right ventricle across the tricuspid valve. So right atrium, left ventricle, and right ventricle. And this is the interventricular septum, and this is the interatrial septum. And as we are slicing like this, as I said, the thumb will be where this green part is. Imagine that you are standing behind the heart and you are just slicing it. So left atrium, left ventricle. So in the next image, this is a mid-esophageal 4-chamber view in a case. And we'll discuss a little bit about the color Doppler. So there will be a button called color. If you press it, you'll get an image like this. And in the color, if you see, the upper part is red. It just means that whatever blood or whatever flows towards the transducer, here will be your transducer. From here, it is sending out signals. So whatever is flowing towards the transducer will be red in color. Whatever flows away will be blue in color. So something is flowing from the left ventricle into the left atrium across the mitral valve. So that is a small mitral regurgitation that you can see. This we'll keep in mind so that we can interpret further images. Now, what is mid-esophageal 2-chamber view? If you look at the screen, you are just slicing it at 90 degree. So now your slice is passing through the heart at 90 degree. So if you're imagining a heart, your thumb is along the upper part of the heart. So your heart is here, you're just slicing it. So whatever structure comes close to this green line will be the anterior wall, and whatever is opposite to that will be the inferior wall. So you are able to see the anterior and inferior walls of the left ventricle. And as said before, this has to be the left atrium. This is a mid-esophageal view. So you can see left atrium, mitral valve, and the left ventricle. So now what we have analyzed is in 0 degree, we have got a 4-chamber view. And at 90 degree, we have got a 2-chamber view. So literally you are transecting the heart in 2 perpendicular planes. And from this, you can gain a lot of information. You can see if the walls are moving well or not. So anterior and inferior walls, whether they are moving well or not. And if you look at the ejection fraction, which many people are interested in, it is just the ability of the heart to contract well. So how well is it ejecting, or whether it is able to contract fully. So if you know the end diastolic volume of 4-chamber and 2-chamber, and also the end systolic volume in 4-chamber and 2-chamber, you can use this formula. Ejection fraction is equal to end diastolic volume minus end systolic volume divided by end diastolic volume. So for 4-chamber view and 2-chamber view, you can calculate it separately. So you are getting an idea about how it is in one plane and also its perpendicular plane. Suppose ejection fraction is 60% in one view and 50% in another view. As an approximation, you can take the average of the two. So 55 will be the ejection fraction. So this view is very useful in identifying any motion abnormalities as well as calculating ejection fraction, these two views. Now, just like we have gone to 90 degree, if you further increase it another 30 degree, that is to 120 degree, what you will get is the long axis view. So I'll try to orient it a little bit better. So you have already increased the angle to 90 degree. Now you are slightly moving it to another 30 degrees. So that total angle is 120 degree. There you can see that it is passing through the aorta. And wherever thumb is, that will be the green line. And that will come towards the left-hand side of the screen. So you have aorta here. And which chamber empties into the aorta? It is the left ventricle. So left ventricle, aorta, and probe is closer to left atrium. So we are seeing the left atrium, left ventricle, and the aorta in this view. So 2-3 things. If you put color Doppler here, you can see that something is flowing from left ventricle to left atrium. So that has to be mitral regurgitation. Similarly, when you put color Doppler across this is in fact Dr. Saravanababu sir's image, which sir has taken. So in this, when you're putting color flow across the aortic valve, you're getting a flow into the left ventricle from the aorta. So that is an aortic regurgitation. One more utility is another thing other than ejection fraction, which many people are interested in, is calculating the cardiac output. So not to, like if you want to calculate the cardiac output, we are assuming that this area is a cylinder. So for a cylinder, the volume of the blood in the cylinder is given by the formula pi r square h. So to calculate the volume in a cylinder, we have to know the radius and the height. We are assuming that this area is a cylinder. So suppose in one heartbeat through the cylinder, X volume of blood is passing. And there are 60 heartbeats in that patient per minute. So if you multiply the heartbeats into the volume in the cylinder, you will get the stroke volume into heart rate, will give you the cardiac output. So to calculate the volume of the cylinder, this is not a must know or anything. To those who are interested, I'm just mentioning. So if you can calculate the diameter of this left ventricular outflow tract in this image. If you know the diameter, half of it will be the radius. So you can use it for radius in this equation. We'll come to this later when we measure the, or when we are discussing about further measurements. So please know that we can look at MR, AR, contractility as well as LVOT diameter from this view. Now, I would like you to pause here a little bit. Previously, if you remember the image, our probe was a little bit more down. Now, in the same view, the probe is slightly pulled up so that your rays are passing across the aortic valve level. So previously it was slightly lower down. Now it is slightly up. There, if you are looking at around 20 to 40 degree, you will be cutting across the aortic valve. So this is the aorta. Aortic valve will come somewhere here and you're slicing across it. So that what you're seeing is the aorta in the view, aortic valve in short axis, a cut section, and this structure is wrapping around it. So basically, you have left atrium, which is where the structure to which probe is close to. And from the left atrium, just next to that, separated by a septum, you have the right atrium. And after the right atrium, you have the right ventricle. And this right ventricle is kind of covering the aorta and going. So in this image, if you see, this is the right ventricle. Right ventricle is just covering this structure. That is the aortic valve, which is what we are obtaining here. So 20 to 40 degree around, if you cut at a slightly higher level than the mid-esophageal four-chamber view, you will get this view, which is aortic valve short axis. This view is good for seeing the valve morphology and whether, and some contractility of the right ventricle, any communication between the atria, that is left atrium and right atrium, tricuspid regurgitation, all these can be seen in this view. Now, if I, from the same point, if I slightly, now we are at 20 to 40 degree, if I slightly increase it a little bit more, I can slice the heart up a bit more. I can slice it in a bit more angulated manner. So that is the right ventricular inflow outflow view. Here, if you see, you can see the right ventricle contracting very well. You can see the tricuspid valve because RA opens into RV through the tricuspid valve. And you can see another valve after that, which is the pulmonary valve. So the clinical utility, now you can look at both these images. Both the images are from the same patient. So if you look here, this area is not at all contracting. So this is part of the right ventricle, which is not at all contracting. Same patient, we started on dobutamine. And you can, this is actually, I've cropped a bit of the video. That's why we are seeing it in a distorted form. But this area is contracting much better. So if you can look at the right ventricle, we can see that RV is contracting better here. So that is RV inflow outflow view. Now same thing, we have already cut till 60 degree, just make it 90. And what happens is it slices through the right atrium completely. So from the previous way, wherever the thumb is, that will be the head end or upper part. So from here, it has gone here. So it is cutting through SVC here. So that will come near the green line here. We have SVC, right atrium and the IVC. So if you can see any communication. So if this is right atrium, this is the left atrium because probe is closer to the left atrium. Left atrium, right atrium, superior vena cava and the inferior vena cava. That is the image that we obtain here. So if you put color there, you can see that some communication is there between this chamber and this chamber. We know that this is left atrium and we have seen that in bicaval view, this will be right atrium. So it is a communication between the left atrium and the right atrium, which is an atrial septal defect. Now we'll proceed to the transgastric views. Here I have described only two views. If you see here, we are reaching the undersurface of the heart and we are antiflexing so that the rays are directed in this fashion to cut the heart. So transgastric mid-papillary short axis view. In this, we are antiflexing the probe, pushing the probe into the stomach and it is from the inferior surface. So whichever area comes closer to the probe here is the inferior surface of the heart. From that, we are slicing the heart. So same dictum, whatever is closer to the probe, this is inferior. What is opposite to inferior? That has to be anterior. So we have the inferior wall of the left ventricle, anterior wall of the left ventricle. And wherever, this is at 0 degree. So wherever our thumb is, that is often the lateral part. So this is the lateral wall of the heart, and this is the septal. So we have inferior, anterior, lateral, and septal. So the relevance of this is that depending on which part of the heart is not contracting well, we can identify which coronary artery is involved. I would like you to focus only on these two images, this two chamber as well as the mid-papillary short axis view. So anterior wall, what is the artery which commonly comes in the anterior wall of the heart? That will be the left anterior descending artery. So the anterior, and I'll just leave it at the anterior wall alone. So anterior wall will be supplied by the LAD or left anterior descending artery, and the inferior wall is often supplied by the right coronary artery. So you have the anterior wall and the inferior wall supplied by LAD and right coronary artery in most of the cases. And which artery is seen in the lateral wall? It will be the left circumflex artery. So this region will be the anterolateral wall, and this region will be the inferolateral wall. So I'm sorry. I apologize. So this will be the anterior wall of the heart, and this will be the inferior wall of the heart. So LAD supplies the anterior wall, right coronary supplies the inferior wall. And the inferoseptal wall, which it can be supplied by either the right coronary artery or the left anterior descending artery. Similarly, usually left circumflex artery supplies the anterolateral wall, and here anterolateral wall can be supplied by either left anterior descending artery or the left circumflex artery, and the inferolateral wall can be supplied by either the right coronary artery or the circumflex artery. So basically LAD, RCA, here it can be LAD, LCX or LAD, here it can be LCX or RCA, and this region can be either right coronary or LAD. Now, this view is also useful for seeing whether TE filling is adequate or not. So, if you look at this panel, the papillary muscles are coming together very well, which means it is almost touching each other. So, this is called the kissing papillary muscle sign, seen in extremely hypovolemic patient, and compared to the left panel, you can also see that it is an extremely hypertrophied heart. So, filling status can be obtained from this, and the regional wall motion abnormality can also be seen from this mid-papillary short axis view. Now, same, we were cutting at 0 degree. Now, when you are cutting at 90 degree, what you're seeing is wherever the probe is close to, that is the inferior wall, and this is the anterior wall. So, you're seeing it in a perpendicular plane. Third is deep transgastric 5-chamber view. We have pushed the probe in further. So from here, we have pushed the probe further in till the deeper part of the stomach, so that you can look at the heart from the apex. So if you look here, this is the apex of the heart, and this is where the probe is. So if this is the apex of the heart or left ventricle, this will be the aorta. So this is left ventricle, aorta, and this is the left atrium opening into the left ventricle. The utility of this image, again, if you put color Doppler there, you can see the flow from aorta into the left ventricle in certain cases. So what flows from aorta to left ventricle? It will be a aortic regurgitation. Similarly, previously we have discussed about the cardiac output measurement. So suppose we already know that the volume is given by formula pi r square. We have calculated radius or diameter from the long axis view. Now what we can do is we need height of the cylinder. So imagine, like in a general scenario, distance or velocity is distance traveled in 1 second. So if the time is 1 second, then distance equal to velocity. So if I can calculate the velocity of the blood that is ejected in a single heartbeat, that will give me the height of the cylinder. I hope it's clear. So, being a cylinder, the center part will have higher velocity and there will be frictional forces at the side of the cylinder, so the velocity will be less. So if you want to measure the velocity across the entire cylinder, you will have to integrate different velocities. So this is velocity time integral. That is the blood or velocity of the blood that is flowing across in a single heartbeat, that is giving you the height of the cylinder. So if you can enter into the machine's algorithm the LVOT diameter and the velocity time integral, it will calculate and give you the stroke volume. That into heart rate. If you can enter the heart rate, that will give you the cardiac output. So that is one more utility. So you can calculate ejection fraction, contractility, regional wall motion abnormality, mitral aortic regurgitations, presence of any interatrial communication, as well as cardiac output from the TE views that we discussed. So to conclude, I hope we can answer this. There's nothing called inferior coronary artery. So which coronary artery supplies the region that is shown by the arrow? Anteriorly by LAD, inferiorly by right coronary artery, anterolaterally by left circumflex or LAD, inferolaterally by RCA or left circumflex, and the inferoseptal region will be supplied by right coronary artery or LAD. So answer to this question is right coronary artery, since it's the inferior wall. Second question was, what is the structure marked by the arrow? So this is a bicable view. In fact, it's something called modified bicable view. But anyway, this is left atrium and the red arrow is showing a right atrium. So these are my references. Thank you.
Yes, thank you, Dr. Mamatha, for a wonderful presentation on the basic views. Also, you narrated the utility of those views in the perioperative management, like volume status assessment, assessment of regional wall motion abnormalities, and the assessment of grade of severity of MRs and aortic regurgitations, and so on. So, so now the transthoracic echocardiography used in non-cardiac for the non-cardiac anesthesiologist in the operation room, as the indications has been expanded to multiple levels because during the surgery they may not able to assess the do a transthoracic echo to assess the heart. So in those kind of situations, they can use a transesophageal echocardiography for better understanding of the volume status or the cardiac function, all those things. So the basic views, there were almost 28 views has been recommended by the societies for the proper cardiac examination. So all those views are very much useful in cardiac surgical setups. But for non-cardiac surgeries, these views which you have been described are very much useful for a better understanding and better patient management. So it was a wonderful lecture, and the pre-test and post-test might have been a little bit enlightened the understanding of the topic. And there were a few questions in the chat box which we can discuss at the end of the all sessions. Now we are next we are going on to the next topic of the today's session, that is the use or utility of transesophageal echocardiography in the critical care units. So the critical care unit where the patients are in a very critical state, and there will be assessment of the cardiac functions may not be that much visible with the transthoracic echocardiography. So where the transesophageal echocardiography has also extended its role in the management of patients in the critical care units. So I like to invite Dr. Rohini to take over the next topic on the role of transesophageal echocardiography in critical care, with many challenging cases which she has gone through in her practice. Over to you, Dr. Rohini.
Good evening to everybody. I'm Dr. Rohini. I'm a consultant cardiac anesthesiologist at Apollo Hospitals, Trichy. Before beginning, I would like to thank Meenakshi Sundaram sir and ISA branch of Puthukkottai for giving me this opportunity today. So let's not waste any more time. We'll just dive into the topic today. So before we start off any topic, I would like to question this topic as to why we need to know this. So why do we need to know? Why do we need to do transesophageal echocardiography in a critical care unit? So as anesthesiologists, we are expected to play many roles. We are not just perioperative physicians. Sometimes we act as guidance and counselors to patients. We act as resuscitators. We have to make decisions. Last but not the least, we have to manage our surgeons as well. So when we do so many roles, echocardiography is a fantastic tool. And I would say that every single anesthesiologist should have a working knowledge about using echocardiography. It is like the new age stethoscope, and this is one single tool. At least for me, it has changed the way I practice immensely. The patient management outcomes, everything has been incredibly different before and after use of echocardiography. So I would like to say echocardiography is like the third eye of Lord Shiva. It permits us to see what the naked eye cannot see. So what is the role of TE in critical care? Mainly in critical care units, we see that patients come to us in a very decompensated stage, wherein there is a lot of cardiorespiratory compromise. So we need to characterize these disorders better in order to manage our patients better. So when, suppose a patient comes to you with hypertension, so there is a lot of confusion as to, do we have to use fluids, do we have to use inotropes, pressors, what exactly is the right way to go about it, what exactly is happening to the patient. Yes, I understand there is a decrease in pressure, but why there is a decrease in pressure, what exactly is happening, how best can I manage it? So for this, always I would recommend go by your echo knowledge, do an echocardiography and then decide the modality of treatment. And it is not just in diagnosis and management. It is not limited only to diagnosis and management, but it also is extended wherein you can see, you can intervene, you can give a particular type of therapy, and you can see if the heart is recovered or not, if the patient's hemodynamics have improved or not. So, I mean, my previous speakers, both of them, they were fantastic. They have covered a lot of things and they have made my talk very, very easy. So if you want to go back and do a little bit of more reading, this is this AC guidelines and standards for performing a comprehensive examination. As it was discussed, there are about 28 views. You need not know all of them. Few of them, most important ones, are what we're going to discuss today. So, and why TE is required in a critical care unit? Because many of the patients in a ICU will be on ventilator, they'll be obese, they may have chest wall injuries. Adequate positioning, adequate imaging may not be possible with transthoracic examination. And also sometimes, especially in critical care units, many times you're asked as a physician to know if the patient has infective endocarditis, prolonged fever, you are not able to find out any other cause for fever, you've done all the tests, you want to rule out infective endocarditis. In these kind of patients, where insufficient diagnostic information is there with transthoracic examination, you will do a TE. So why is this important? Okay, again, there was a very interesting paper. This was by the task force of the European Society of Intensive Care Medicine. Assessing the indications they said mainly were to assess hemodynamics to rule out endocarditis. I would want to draw your attention to the last two things. The change in diagnosis and the change in management. Nearly 50 to 80% of these patients managed in the critical care units had a change in diagnosis and a change in management once a TE was done. So this is the impact of TE. This is the impact that echo can give you in a critical care unit. So contraindications, complications, already Dr. Mamatha has dealt with it, so I will not go into this again. So now, okay, let us leave alone all the 28 views. You do not have time, your patient is crashing, you don't know what is happening. So for this, I would say 4 or 5 basic views. If you know these, you will be able to arrive at some conclusion as to, you will know some idea as to what is happening and how you have to proceed forward. So they have described beautifully and in detail as to how to obtain these views, what exactly are the structures seen in each of these views. Now we will deal with each one of these views individually. And before that, I would draw your attention to this website. This is a virtual trans-esophageal echocardiography, PIMED Toronto. University of Toronto has designed this website. It's a fantastic website, especially for beginners. If you want to check like how the probe is coming in, how the ultrasound probe cuts the heart, what views you get at which position, and what exactly you will be able to see in each of these views. This is a fantastic website. I would urge all the students to go back and refer this website for more images, videos, and for better understanding of TE. So let's start off with our first view. This is the mid-esophageal 4-chamber view. Again, Madam has elaborated on how to obtain this view and what are the structures. So basic structures that you see here are the right atrium ventricle, left atrium and ventricle. So what this view is mainly used for is to determine the chamber size. Is it dilated? Is it collapsing? How is the ventricular function? How is the right ventricle? How is the left ventricle? And also the valves, mitral and tricuspid valves. And also it helps to rule out any effusions. So this is a normal, relatively a normal functioning cardiac image. So let's go to the next one. Let's see what the pathologies will do. So for reference, on the left side, I've kept a normal image. On the right side, if you see one thing very visibly that you can see is that the left atrium and the left ventricle are enlarged. Left ventricle is barely contracting, it is struggling. So if a patient like this comes to you with hypotension, you have to be very careful about fluid administration. So once you put in an echo probe, once you have this patient with hypotension, when you put in an echo probe, you know that the ventricle is struggling. So at this time, you would rather go in for an inotrope or an inodilator rather than giving fluids for resuscitation. So it's just a marked visible, as Dr. Mamatha already said, how to estimate EF. So if you're able to estimate the EF, you can do it. But in case you do not have the time to do a complete EF calculation, just by looking at it, looking at the ventricle, you know that it is struggling. It is not contracting at all. So this is a case of severe ME dysfunction, wherein you have to be very careful about how you're going to manage the fluids, how you're going to manage your inotropes. So again, left side is the reference image, relatively a normal heart. On the right side, you can see the first thing that can strike to you in this is that the right atrium and the right ventricle are enlarged. Normally, if you see on the left, the image on the left, the right ventricle is much smaller. It is lesser in compared to the left ventricle. It forms about roughly say 2/3 of the size of the left ventricle. Compare the size of the right ventricle on the left onto the image on the right. So it is grossly dilated. It is the left atrium, the right atrium and the right ventricle are grossly dilated. So where do you see this kind of a scenario in your ICUs? In case there is a thromboembolism, pulmonary thromboembolism, these patients present with acute right ventricular failure. So you can see this, there is a visible clot that is there in the right ventricle. So acute onset right ventricular failure, please be careful that this could be secondary to elevated pressures in the pulmonary arterial system, which could be or it could be because of any thromboembolic phenomenon. And here again, a comparative image, left normal, on the right, if you can see, the mitral valve. There is something structurally abnormal with the mitral valve. Normally, the leaflets should be in an inverted V shape. They should be touching each other. They should be coapting. The leaflet tip should be like this, directed towards the left ventricle. Here, if you see the posterior mitral leaflet, it is just going up like this. It is not touching the anterior mitral leaflet. It is going into the left ventricle. The leaflets are not coming towards each other. In fact, they're going like this. So what is happening is there is a coaptation defect. So this is what in the next image you will see that if you put a color Doppler across this kind of a valve, you will see that there is a regurgitation jet. This is mitral regurgitation jet. So this can happen in acute scenarios if the patient has had an acute MI, comes with a papillary muscle rupture or caudal rupture. The leaflets can prolapse or go into flail like this and cause an acute severe mitral regurgitation. So the patient, when they come to you, they'll be very breathless, they will be in pulmonary edema, cold, clammy extremities. So the way you manage this patient will be very different. Again, just put in an echo probe. When a patient comes to you in a decompensated stage, just put in an echo probe, you will know what is happening. And here, next image, here we see the one that is marked with the star, that is a pericardial effusion. You can see what that is doing to the heart there. So again, pericardial effusion, pericardial tamponade again is a medical emergency. Unexplained hypotension, it is a form of obstructive shock. So very simple to treat. Very simple to diagnose also, but missed most often because we do not have access to an echo probe. So we are going on giving fluids, we are going on giving vasopressors, we really do not know what is happening. In fact, the appropriate treatment would have just been to put in a pigtail catheter there. So the next view that we are coming to is the transgastric view. This is a transgastric mid-papillary short axis view. So the walls that you see here are the anterior, septal, inferior, and the lateral wall, and two papillary muscles. The red being red being the posteromedial, and the green being the anterolateral papillary muscle. Why papillary muscles are important, I'll tell you in the next video. So this on the left side is a normovolemic patient. On the right side is a hypovolemic patient. Here you can see in the hypovolemic patient, the papillary muscles are touching each other. This is known as the kissing papillary muscle sign. So this patient will do well when you resuscitate them with fluid. Another very good view to assess not only fluid status but also contractility, regional wall motion abnormality. I will again not elaborate because the previous speaker has already dealt with this. But again, if at all you need to know the contractility status, this is a very good view. And also if there is any effusion can also be seen. You can see the black colored thing around the ventricle, that will be the effusion. So again, now this, if you compare this view, the left and the right, the one on the right, this ventricle is again struggling to contract. So there is some regional wall motion abnormality. So how do you decide if the ventricle is contracting well or not? So try and put your, like just put an imaginary dot in the center of the ventricle, in the ventricular cavity, or just place your index finger in the middle of the ventricular cavity. So at that point, you see which walls are, like if this is the ventricular cavity, just put in a finger there. See which wall is coming towards your finger. If the anterior wall is struggling to come towards your finger, but your inferior wall is moving well towards your finger, that means to say it is anterior wall is hypokinetic. Here in this picture, it is more of a global hypokinesia. The entire ventricle is struggling to contract. Compare it on the left side, the ventricle walls are contracting very well. All the walls are uniformly contracting to come towards the center, whereas on the right side, it is just struggling. It is just moving very little. And it is obviously, there is so much of fluid overload. The end diastolic volume is high, end diastolic pressures will be high in these kind of patients. So, when a patient comes to you in shock in a critical care unit, do not be scared. So many different kinds of types of shock. So now you will be in a stage to differentiate between these types of shock. Hypovolemic, you already know, kissing papillary muscle sign, look for that. Give a volume challenge to these patients. Cardiogenic, barely contracting ventricle, mid-esophageal fourth chamber, and also the transgastric mid-papillary view will tell you it's a cardiogenic shock. Obstructive shock in the form of a cardiac tamponade or in the form of RA-RV dilatation if it is an obstruction to the right-sided system. We saw how the right atrium and the right ventricle will get dilated in the presence of a thrombus. And distributive shock again is a little difficult. I think we have to keep in mind that we should interpret echo only along with clinical signs and clinical examination of the patient. You shouldn't just look at one image and come to a diagnosis. You shouldn't come to a conclusion. Look at the clinical status also of the patient, because it may be a little difficult for you to distinguish between a distributive and a hypovolemic shock, because ventricles will be contracting well, volume status may or may not be that different between hypovolemic and distributive shock. So always examine the peripheral pulses, how the patient is he warm, is he cold to touch? So always couple the take-home message is that do not just look at the echocardiographic image, but also couple it with your clinical examination. So never be scared when a patient comes to you with shock. Just take a probe, just look for an echocardiography examination. You will decide better, you will manage your patients better. Another very good view for us would be the mid-esophageal long axis view. We see the left atrium, mitral valve, left ventricle, aortic valve, and the aorta, and the bit of the interventricular septum and the right ventricle in this. So in critical care, this is how it looks on the TE image. This is the position of the transducer, and this is how it looks on the TE. So just have a look at this video. This is a patient post cardiac arrest. So in the initial one where the compressions were not effective because the compressions were being delivered onto the RV side, you can see that the aortic valve is barely opening. Whereas once the position was modified, the compressions were given better. You see how beautifully the aortic valve has started opening there. So you can guide your compressions, real-time compressions, to deliver effective compressions. You can make use of TE. Again, another good view here, wherein you can put in a cover Doppler across patients with acute trauma, blunt chest wall injuries. Just put a they can come with acute aortic regurgitation. So this is the image of an acute aortic regurgitation. And dissections. This is TEE is one of the gold standard methods of finding out if a patient has a dissection or not. So they see that flap-like structure that is the pointer that is pointing to in the aorta, in the ascending aorta, so that just adjacent to the aortic valve. So that is a dissection flap. So when I talk about dissection, again, there is another view that is very, very important for us. That is an examination of a descending thoracic aorta. Just once you put in a probe, just rotate it in any of the mid-esophageal. Once you get a mid-esophageal fourth chamber, just rotate the probe, just go 180 degrees behind, and you will see that this is you will find a descending thoracic aorta. So descending thoracic aorta, again, if there is a flap like this, any flap in the aorta, that will be a dissection. Again, another example. So the next view is a mid-esophageal bicaval view. Here we see both atrium, the SVC and the IVC. Why this is important in a critical care unit is because any of our procedures, in case we need to put in any cannula, any CVC, or in case we need to put the patient on ECMO, we need to put in a cannula guide wire. This is a very good view. So on the left hand side, there's a guide wire that is coming in from the IVC. On the right hand side, you can see a cannula passed over the guide wire. And also to rule out any persistent hypoxemia patients, if they have any PFO or not, if you can do an agitated saline test, you can just inject agitated saline through your IV, through your CVC if it is there, and within 2 to 3 cardiac cycles, if it is reflected in the LA side, you know that the patient may have a PFO. So unexplained hypoxemia, you can rule out a PFO in this. Also, any interatrial septal defects you can very well look at in this video. And nowadays, since we are looking at goal-directed fluid therapy, SVC and IVC dimensions are also important for us in order to know volume responsiveness of a patient. There is something known as a distensibility or a collapsibility index that is present to assess the volume status for a patient, depending on the measurement of SVC or IVC respectively during inspiration and expiration. Another common indication for role of TE in critical care is to rule out infective endocarditis. See, this is a patient with infective endocarditis. That small finger-like projection that you're seeing atop the mitral valve. On the right-hand side is a 3D image of the mitral valve. That small finger-like projection that is coming above the valve, that is the vegetation. So to quickly summarize, just 4 views will give you enormous information, and you can do wonders to your patient. Just to quickly summarize, I will say mid-esophageal 4-chamber view to rule out effusions, any thrombus, biventricular function, and to look for any valvular lesions. Mid-esophageal long axis views to monitor the quality of your CPR, to see your left ventricular function, to rule out effusions, and both mitral and aortic valves can also be seen. Any pathologies related to this. And also, we have to add dissection also there. Any acute dissections can also be seen in this view. A transgastric short axis mid-papillary view, again, very good for knowing volume status, regional wall motion abnormalities, and any effusions that are present. Bicaval view for any procedural guidance and volume responsiveness. So this is a quick summary. Just these 4 views are so fantastic. They'll give you so much of information and help you manage your patients better. So TE is not just restricted to the heart, but there are other applications of TE as well. When we go beyond the heart, we can image beyond the heart as well. An upcoming field is ultrasound for lungs. So this again is a very, very good paper wherein it describes in detail about different pathologies on lung which can be picked up by TE. So here just commonly what we see is any pleural effusions. Patients presents with hypoxia, what do you do? Just put in a probe, you know, there is an effusion. This is classically known as a jelly bean sign, where the lung appears like a jelly bean that is floating in water. The dark thing that is the effusion that is there, and it is very easy to estimate the amount of effusion also. If you look at the cross-sectional area of this fluid accumulation, anything less than 20 centimeters square will be a mild effusion, 20 to 40 will be a moderate effusion, more than 40 will be a large effusion. So in case you need to know what procedure, do you have to tap this patient or not, do you have to put in an ICD or not, again, estimating this cross-sectional area will give you good guidance as to how to quantify this elevation. Not only this, there are so many other things that you can do with lung ultrasound. You can know if there is any ongoing consolidation, atelectasis, and actually you can, depending on the position of the probe, you can examine each segment of the lung beautifully. We'll have that talk for probably another day. And it's not just lung. I mean, if you put in any of these transgastric views, even liver can be imaged very well with transesophageal echo. So any liver masses that is in the middle, the one on the lower hand, that is actually some carcinoma of the liver. That is a hepatic tumor that can be seen. The top left, that is the hemoperitoneum. That is there is free fluid above the liver. On the right hand side, the right far end of the screen, you can see that is an IVC thrombus in the renal cell carcinoma that is extending into the RA. So I would like to say that do not think that TEE means only the heart, but it can image other organs as well, other pathologies as well. So it is just a remarkable tool, and thank you all for your patient listening. I would, again, as I began, I would like to conclude that it is an excellent armamentarium for an anesthesiologist to have, and as budding young anesthesiologists, everybody should have a working knowledge of echo. Thank you all again.
Yeah, thank you, Dr. Rohini. It was an excellent talk, and you almost demonstrated all the pathologies which have been diagnosed by TEE in the critical care unit. And before before discussion, there are a few questions in the chat box. The question was given by Dr. Muthukumar Rajagopalan. So he is asking, how do we insert the TEE probe, whether using a laryngoscope or a blind method, which one is safe? So this was a question, and Dr. Mamatha or Dr. Prasanth wants to answer this question.
Dr. Prashant, would you like to answer?
No, ma'am.
So both blind and laryngoscopy methods are used. But if you ask me like what is commonly used, it is blindly. Like mostly with just minimal manipulations, you'll be able to insert a TEE probe that is appropriate for the age of the patient safely. But in case there is difficulty, then you can do a laryngoscopy and then insert the probe. So both methods are there. What is common is blind insertion, gentle blind insertion with minimal maneuvers.
With the permission of the moderator, if I can I pitch into this question?
Yes, please.
I think we are moving towards an era where recommendations are going to change, where we have to insert a TEE probe with the use of a video laryngoscope. I think that is where the world is moving towards nowadays. Many people have started using insertion of TEE probe with video laryngoscope assistance.
Yeah, as you told, from Sree Chitra Tirunal Institute, we participated in a multi-centric study on this video laryngoscopy, as well as, in adult patients, comparing the video laryngoscope and blind insertion methods. And the results of the study is published in the Journal of Cardiothoracic and Vascular Anesthesia with the conclusion. It's a multi-centric study involving the 5 tertiary care hospitals all over India. And the conclusion came as the video laryngoscopy attempts were less in insertion of the TEE probes in compared to the blind, and also the injuries related to the TEE probe insertion was also less in compared to the video laryngoscope insertion compared to the blind insertion. So the video laryngoscope always have a higher hand in inserting the TEE probe to reduce the complications as well as reduce the number of attempts in TEE probe insertion. But the case was entirely different in case of pediatric patients, where we did a study just 2 days before only it published in the Journal of Cardiothoracic and Vascular Anesthesia. The same study was tried in the pediatric population, and we found that the insertion attempts and the injury related to the TEE probe insertion, there was no difference in the 2 groups, the blind group as well as the video laryngoscope group. For adult patients, the video laryngoscope guided insertion of the TEE probe as a upper hand, whereas in pediatric patients there was no significant difference. So there was a conclusion from the 2 studies from our institute. And the next question is, What about the esophageal injuries? Can we insert the key probe in patients having esophageal varices? So, what is your experience and what is your opinion on this? So, this was the question, and Dr. Mamta, can you answer this question?
Yes, sir. Esophageal varices is a relative contraindication for TE insertion. But if you ask me personally whether I'll insert for a patient who has esophageal varices, I will not insert. Because according to all the dictum states that whenever the risk is more than the benefit offered to the patient, ideally it has to be selected on a case-to-case basis. But personally, I will not insert for any patient with esophageal varices. It is at the discretion of the physician since it is a relative contraindication.
So,
Madam, Mamta madam, then before inserting TE probe, whether routinely you will check whether the patient is suffering from esophageal varices or esophageal anomaly.
No, sir.
It is not possible also. Then
Usually we don't check,
see,
sir.
the medical gastroenterologist doing upper and GI scopy invariably writes there is esophageal ulceration. Stress ulcers are seen. Without
Yes,
that,
sir.
you cannot have any finding. So at that point of time, what will happen to the ulcer if the TE probe is inserted? It will be there, but most of the time nature heals everything. That's what I feel.
True, sir. I agree. There are actually, it is at the physician's discretion since it's a relative contraindication. I totally agree with your point of view, sir.
yes. So, the next question was about the cardiac output measurement with TE. So, Dr. Muthukumar has asked about how accuracy is the cardiac output calculated from TE and PA cath. Because we all know that PA cath guided cardiac output measurement is a gold standard. So now patients who cannot able to insert the PA cath, so T guided cardiac output measurement. So among these two, which is accurate? So what is your opinion on this, and what are the studies saying like which is accurate? Dr. Rohini, can you answer?
I think, I think for cardiac output calculation, with respect to TE, it is, we have to keep in mind that there is a scope of error, because if we are estimating the LVOT measurements wrong, we will be calculating the cardiac output wrong because we are multiplying it by a square. So we have to be very sure that we are actually getting the LVOT diameter right before we say that this is the cardiac output. What I would say is, instead of the traditional method, if we can go ahead and look at the aortic, if for example we have a patient who is decompensated, you want to give a fluid bolus and you want to see if the cardiac output increases or not. So what we would do is trace the aortic valve VTI, and then you do your intervention and you then see what is the difference in the VTI, if it increases by a percentage of 10 to 15% or not. So then you will know if your intervention is right or not. So the trending, I think, is after an intervention, the trend that we get is more useful with the TE.
Now, moderator sir, I will put it in the palatable way because I am the one who has not traveled with this TEE. You people are daily in and out living with that. So I think the person who has asked the question is also not traveling with the TEE. So what I can say, this is just like CVP measurement. We used to say the single number is not a matter. The changing trend is a matter, as he said. So even this PA catheter, even if you want to measure the output, it is a cumbersome. So the another point is less cumbersome method is this TE. Less cumbersome method, least cumbersome is only imagination. But we will say that it is a clinical parameter. Before this TE and these catheters, we thought on our own this may be the cardiac output. So that way, as science is advancing, everything will have some pros and cons, definitely. So according to the availability, and instead of nothing, something makes sense. So we can do that way only. It is only a striking the compromise.
Yes.
Yes,
If
yes.
I might add one more point, sir.
Yes,
Yes.
please.
I agree with what Dr. Rohini has said. Maximum error happens with LVOT measurement, because any small error also gets squared in the cardiac output calculation. But though the variability in measurement of cardiac output or the error in measurement of cardiac output by TE is around 16 to 40%. In fact, the variability of PA catheter measurement is also around 20%. So it depends on like you're measuring cardiac output by TE, you're getting a value of 6 liters or maybe 5 liters. And how bothered are you if you're getting a value of 4.7 instead of 5? So though some error factor is there, it is not going to significantly alter the...
Madam, she has made it very clear. It is only the changing trend that matters. It is
Yes,
not
sir.
the
The trend.
absolute number.
Yes,
What she says, you give some fluid, analyze. If something happens right, or else you accept that it is a false
I
measurement.
agree, sir. I
Okay,
totally
so
agree.
that is the reason why we say everything is calculated with AI only nowadays. Even if the ODC curve, ABG, the oxygen saturation is only derived parameter, not the absolute parameter. Same way, whether you use a Swan-Ganz or this TEE, it may be calculated by AI, but the natural intelligence cannot be replaced by AI. That is where we stand. It is not that simple number. It is the changing trend. It is the
Yes,
changing trend.
Yeah,
yes, sir.
yeah, definitely, sir, definitely, sir. So next question was on the TTE will be sufficient in the ICU. Why the need of TE?
Yeah, that was, as I said, I think there was a slide in my talk wherein I said, where are the specific scenarios where you will prefer TE over TT? Where if the patient has chest wall trauma or if the patient is obese, where your TTE images are not satisfactory. So many times we find that transthoracic images are not satisfactory. You cannot really come to a clinical conclusion based on a transthoracic image. So those times I would prefer a transesophageal echocardiogram.
Yeah, you're right, doctor. See, that
And I think the second part says, do you need a ventilated patient? Not required, not really required. Even if I can do TE, does not require ventilation. We do TE on an OPD basis as well. We just spray some local anesthetic, give some mild sedation. I think if the hemodynamics permit, we can still do that. Ventilation is not mandatory for TE.
is it possible to do a TE in a patient in a critical setup without intubation? Patient
If the
hemodynamics or
hemodynamically, I mean, I think airway
patient
management is primary in a patient who has hemodynamic instability. That will take precedence over TE, in fact.
first we have
First,
to stabilize the
stabilize the
patient.
patient and then go ahead.
Yeah, that is much needed. Then the next question is that the TE for liver transplant, what views are useful for seeing the portal veins?
Liver transplant, I have limited exposure. I know that they do use TE for liver transplant, but I have not anesthetized for liver transplant, so probably I couldn't contribute much to that.
In liver transplant, as a dean of Stanley Medical College, which the medical college is a pioneer in government institute liver transplant, but we are doing a conventional radiologist will come there. So what I have seen, they will remove the liver and they will do radiological examination of the liver. That donor liver, they will be doing like that. But even TE, another one, we were not having TE in the theater. So I don't know whether it is to be used or not. But we have done 8 liver transplants in 11 months. But we have never used TE. So I cannot answer that question also. Even though we have seen liver transplant, we have not seen TE. That is the problem.
I know that they divide it into pre-anhepatic phase and hepatic phase, and so once the I think the portal vein imaging, they once the anastomosis are done, they check the
After,
gradient across the
it
anastomosis.
is only post anastomosis they will do. Post anastomosis. So,
But
common sense, I think that he may not be valuable in liver transplant. That is post transplant status. But they are doing that. Radiologist will be in the theater. That interventional radiologist will be inside the theater while we perform liver transplant. So they will be seeing only that external, not the internal like TE. They will not do that scope.
I think because liver transplant involves large amounts of fluid shifts, and these patients are often decompensated with multi-organ dysfunction. Monitoring the cardiac function during liver transplant, again, that would be a great indication.
That will be automatically done, madam. Like your IBP, we will be monitoring, not this TE, for the simple reason It may be, as you people are well versed with the TEE, you may be thinking that is the thing. But even before that, we were assessing the collapsibility of IVC. We were seeing only the CVP. We were seeing only the IBP. So somehow we were doing at that stage. But probably you people have to tell. But the problem is you will never come out of your cardiac unit. So we may not be knowing whether TEE will be significant in liver transplant. If anesthetist engages in that role, if he practices that, it will be good. But I don't think that anybody has talked about TEE in liver transplant even in the conferences. So far, as far I have attended.
But I am aware that they do it routinely. TE is done.
Yeah, it can. Because when a person is well versed, they will be doing it. Because anything, this is just like most of the cases in this bivesicular blocks. Many people will insert a prophylactic pacer. But we were not doing that because we are not well versed with that. That is the reason. If you are having that setup, if you have the facility, if you don't want to take any chance, that is always better. But in a remote setup, at that time we don't know what to do, so we were taking it up, thinking that isoproteinol will act, adrenaline will act. But nowadays they are inserting a temporary pacer, they are doing the surgery, they are removing the pacer. As science advances, people can do anything. So we are seeing that transition. Because previously, when there is a postpartum bleeding, we were doing internal echo artery ligation or that uterus stitches, so many things we were doing. But nowadays, the radiologist comes, he is blocking the artery, then they are removing, again he is removing the block and he is going. So these are all just like a cakewalk they are doing nowadays. Any malignancy, they embolize the artery, which we have never imagined that they can do it like that. We will be having some 8 units of blood, backpacked cells, everything. Same way the TEE will rule the world in future. You people have to take it forward.
So to
Coming
add on
outside
this,
the cardiac also. As Dr. Rohini mentioned, beyond the heart, you should think.
yeah. So to add on this, sir, there are no standard views for getting the portal veins. No standard views has been described for seeing the portal veins, but there are few views has been described for the visualizing the hepatic veins and the IVC during the post-transplant period, the volume status, as well as the IVC and the anastomosis after liver transplant. All those things can be seen. But portal veins, there are few studies which shows that the portal vein velocity pulsatility index, which is a main measurement of the vexus as a part of vexus. There are few studies has been tried in the intraoperative period by seeing the portal veins and measuring the pulsatility index in the portal veins. But there are no standard views so far as been described for the portal vein view in the with the echo transesophageal echo. So as already told, the TE has been not only as beyond the heart. So now its role in the aortic surgeries has also has been become more important. So post surgeries, we can able to see the anastomosis, like for example, the ascending aortic, the descending aortic aneurysms, and the abdominal aortic aneurysms, where they will implant the celiac arteries into the abdominal aorta. So all those anastomosed arteries can be seen, the flow inside the arteries can be seen very nicely with the TE, because if you go down to the stomach and you can rotate the probe towards the aorta, where the anastomosis parts can be clearly seen, and you can measure the velocity where the anastomosis of the celiac arteries as well as the superior mesenteric artery into the aortic graft, which can be visualized nicely with the transesophageal echocardiography. Also, the renal arteries also can be visualized. The flow to the renal arteries can be visualized with the TEE. So after post renal artery implantation during the aortic surgeries, the infrarenal abdominal aortic aneurysms or kind of juxtarenal aneurysms, where they may need an implantation of the renal arteries into the aortic graft, there you can also able to appreciate the flow across the renal arteries with the help of TEE. So we have been doing this routinely in our institute, Sree Chitra, the imaging of the renal arteries as well as the replacement of the aortas and the anastomosis of the aortas in the vascular surgical unit. And the questions are almost over, I think.
If there are no questions, moderator sir, you can pass your concluding remarks.
Yeah. So overall, the presentations were very excellent, and it has been clearly demonstrated the role of TE in the intraoperative period as well as in the critical care unit. So the ECHO website, which has been showed by Dr. Rohini, that PIMET Toronto, so it is very user friendly for the beginners to learn the transesophageal echocardiography, to understand the views and to practice the TE and views, and to practice the movement of the TE probe. All those things are possible with the PIMET Toronto. For the beginners, you should try using it, and you can learn a lot of things from that website. And the TE, the transesophageal echocardiography, is going to create some wonders in near future in anesthesiology. Already the transthoracic echocardiography has created a big path in the way of general anesthesiologists. Now this transesophageal echocardiography is also going to create big wonders, as I already told, in the field of anesthesiology. So we should concentrate more. If you practice more, then we can able to learn more and able to teach more. So with this, one thing you should not forget is that always you should have a clinical examination on the patient before you going to a conclusion, going with the echocardiographic examination. So that is the end of this session, and it was a very nice presentation for all the speakers. And I thank Dr. AL.M. sir and ISA Puthukkottai branch for conducting this wonderful events, and I wish that this to be continued in future also. Thank you very much, sir.
Thank you, Dr. Saravanababu. And now it is my duty to thank everyone. As a person engaged in the field of anesthesiology for the past 36 years, I am seeing the tremendous progress in the cardiovascular and neuroanesthesiology. Cardiovascular, it is tremendous because I have done my diploma in anesthesiology in Madras Medical College, but there daily one ASD we will be operating only one ASD closure, that too if ventilator is available. So if the patient could not be extubated on table, then next case will be cancelled. Then we were going to railway hospital to learn open cardiac anesthesia. Those days. Nowadays they are doing device closure. But from that, the way in which that postgraduate, starting from the postgraduate, Dr. Prasanth, the way he has described about this TE probe anatomy, he has discussed about the anatomy, which was very clear. That too is video. That's what we require, because this reaches the young minds, postgraduates and young graduates. Of course, people who want to be young like me. So he has described very clearly about the anatomy, the probe tip, how they are moving. Now what I have seen several times in the theater just to see TE, I have gone, but nobody has explained me. There are two wheels. Now only I recollect I have seen outer bigger one and inner smaller one, but I don't know what they are doing. Simply I think like any other, we are doing with bronchoscope. So right, some manipulation is done. He is very well explained, and it was followed by that views. It is excellent. Dr. Mamatha madam is extremely good in delivering the lecture. So both of them have proved they are real cardiac anesthesiologist, followed by our home team member, Dr. Rohini. Even though the in-laws are belonging to Puthukkottai, she is in Apollo hospitals, and she is good at this critical care also. So her passion is TE in critical care, which I have heard her lecture frequently. And these three have proved that they are excellent cardiac anesthesiologists. And in future, I am afraid people with just MD, they cannot anesthetize any cardiac procedures. Even the surgeons may not encourage. That is, I take it as a disadvantage, because we were doing everything at that time just by MD qualification. Now people used to say, in which area you are qualified, then they will say, sir, I'm just MBBS. I used to say, don't say like that. MBBS itself is a very big thing. Now, in due course, if a person is called to anesthetize a cardiac case, then he may answer, sir, I am just an MD. So you people have made it like that. Just MD anesthesiology graduate, they are going to reply, and wonderfully well the teacher, Dr. Saravanababu, because Dr. Mamatha and Prasanth felt that he is a teacher. So fortunately, he belonged to Tamil Nadu, and now he is in Madurai. So the All India Institute Madurai will soon have a open cardiac setup under the headship of Dr. Saravanababu. So I wish you all the very best in your future also. Please keep experimenting, try all your research methodology to keep the ISA flag high in the international area, because you are, it seems you are very good cardiovascular anesthesiologist, all the four. So my best wishes for all of you, and I request Swastika Clarinet to pass the concluding remarks.
So, thanks to all the dignitaries present here. Clarity is really glad that you all gave the opportunity to host the session in our platform, and I hope you all had a seamless experience. And again, thank you so much for your valuable timing. So, with all your due permission, I am concluding the session in here for today and looking forward to host you again. Thank you so much.
Thank you. We'll call all of you tomorrow. Thank you very much.
Thank you so much. Good night.